Chairman, ladies and gentlemen, good morning again. I will try to not have too much overlap with my previous presentation this morning. So first, I have to define what is cor pulmonale, even though Michael did it very well this morning. Just to remind you that the main definition is an echocardiographic definition, and it associates right ventricular dilatation, as you see here on a transthoracic echo, with a paradoxical septal motion during end systole. And Michael said that yesterday, this paradoxical septal motion is mainly related to the inverted pressure gradient between the right ventricle and the left ventricle. And you can see here that the pressure in the right became higher than the pressure in the left during end systole, reflecting the paradoxical septal motion. And I think now it's much easier and much better for the patients to observe this inverted pressure gradient just by putting the probe on the chest rather than inserting a catheter into the right and into the left ventricle. So a very important thing that you have to understand regards the coupling between the right ventricle and the pulmonary circulation. And you can see here that it's in animal, it's very easy to have a PV loop of the right ventricle during diastole and systole. And you know that from this PV loop, you may have the end systolic elastance of the right ventricle, which is something representing the intrinsic performance of the right ventricle. And this is the change in pressure during systole divided by the end systolic volume. But you have also, in the same time on this PV loop, the pulmonary elastance, which represents a surrogate of the right ventricular afterload. And what is really important is that the performance of the right ventricle is the ratio between both, which represent the coupling between the right ventricle and the pulmonary circulation. And if you look at this study in animals, you have here in different animals, you can see different arterial elastance, but in response, you can see different right ventricular elastance. And so you can see that the coupling is the same and the performance of the right ventricle is optimal. This is at baseline. And if you look at during hypoxia in these animals, there is some pulmonary vasoconstrictions. And so you can see an increased right ventricular afterload. And you may visualize that the right ventricle is able to adapt a little bit to this increased right ventricular afterload just to maintain optimal the coupling. And the problem in acute cor pulmonale is that this coupling is not optimal and there is a decrease in the coupling between the right ventricle and the pulmonary circulation. Either because in most situations you have a very significant increase in right ventricular afterload, as you may observe during massive pulmonary embolism or acute respiratory distress syndrome, or in some situation because you have some patient with decreased right ventricular contraction under mechanical ventilation for a respiratory problem, and the slight increase in RV afterload induced by mechanical ventilation is able in this situation to induce an uncoupling between the right ventricle and the pulmonary circulation, and so to induce an acute cor pulmonale pattern. And I will show you some very brief cases regarding right ventricular infection and septic cardiomyopathy, as you may have with an injury of the right ventricle. So there are the most common situations regard a significant increase in right ventricular afterload, either by a proximal obstruction of pulmonary circulation. I know it's not very common to have a pulmonary embolism under mechanical ventilation. I want just to say that it's not the right treatment, but sometimes you may have to put the patient under mechanical ventilation because of cardiac arrest or because of very severe shock. And you can see, for instance, in this kind of patient that we reported a few years ago in a large series of 161 patients in the ICU, that the incidence of ACP was 60%. This is much higher than the incidence of ACP that you may have in this kind of patients in the true life, for instance, in the ward, but probably that in part mechanical ventilation in this patient may increase the incidence of acute cor pulmonale. Look at this patient who was under mechanical ventilation. You can see the huge increase in RV size. Here, look at how the right ventricle is big, a paradoxical septal motion, and in the same time, using the TE, you can see the thrombus, the clot into the right pulmonary artery. So at the bedside, in this patient under mechanical ventilation for massive pulmonary embolism, you see the acute cor pulmonale and we will discuss later on the treatment, and you diagnose the pulmonary embolism. So very briefly, because this is not the main topic of my presentation, but there is some recommendations in this situation for the treatment. There is a specific treatment, as you know. In this situation, you have to thrombolize the patient. And just to show you before thrombolysis, this is the paradoxical septal motion, and 4 hours later, the thrombolysis, you can see a complete normalization of the right ventricular function. But what is also interesting in the recent recommendations of the European Society of Cardiology regarding massive pulmonary embolism is that there is some recommendation regarding respiratory support. And if you have to ventilate this kind of patients, once again, which is very uncommon, you have to ventilate this patient with the low tidal volume, absolutely to keep the plateau pressure as low as possible. And probably that 30 centimeters of water is too high, and probably that as low as possible. So this is for proximal obstruction into the pulmonary circulation. Now you know that you may have distal obstruction of pulmonary circulation, as I show you this morning, so I cannot spend too much time on this part. Remember this review from Lara Price. And just I want to, it may allow me to answer to the question of Frances regarding how to suspect in this situation acute cor pulmonale. And I show you the data that we did not yet publish in more than 700 ARDS patients under protective mechanical ventilation who all had an echo during the 2 days following mechanical ventilation. And remember that the main parameters which were associated with the occurrence of ACP, and we decided to validate a score, and we just gave 1 point per item, and you can see that we have a score between 0 and 4. And look at how the incidence of ACP according to the score. If the score is below 2, only 0 or 1, you can see that the incidence of ACP is very low. So probably you have just to do the echo on demand according to the clinical situation, the hemodynamic status, and so on. But you can see that if the score is 2, 3, or 4, you can see that in this situation, the incidence of ACP becomes very, very high, close to 70% when the score is 4. And so in this situation, we may recommend to perform a systematic echocardiography to detect the acute cor pulmonale and to adapt the respiratory settings. The third part regards the acute cor pulmonale, which is mainly related to the application of positive pressure ventilation, and so the uncoupling between the right ventricle and the pulmonary circulation. So look at this patient. This patient had an inferior myocardial infection. You can see the EKG, and so the infection was extended to the right ventricle. And it's very unusual in this situation to observe the acute cor pulmonale. As you know, most of the time you have right ventricular systolic dysfunction with right ventricular dilatation, but no acute cor pulmonale. But actually in this patient, you can see some pattern of ACP. Look at the right ventricular dilatation, and look at the paradoxical septal motion. This is mainly due to the fact that this patient was under a positive pressure ventilation, inducing some uncoupling once again during the right ventricle and the pulmonary circulation. You have the same illustration in the septic cardiomyopathy. Look at this patient who was admitted in our unit for a septic shock from urinary origin. She was ventilated. There was no acute lung injury or severe acute respiratory distress syndrome. We can say that the gas exchange was in a normal range, but when we perform TE because of shock, you can see dilation of the right ventricle and paradoxical septal motion. So a pattern of acute cor pulmonale, once again, mainly due to the association of the decreased right ventricular contraction due to the septic process and the application of a positive pressure ventilation. So this uncoupling between the right ventricle and the pulmonary circulation. So a few words now regarding the non-specific hemodynamic support that you have to do in case in front of a patient with shock related to acute cor pulmonale. First, of course, you have to adapt respiratory settings, and then I don't want to speak too much about that because this morning I present you the right ventricular protective approach that we promote in severe ARDS patients. You have to limit fluid expansion, and you have to correct the mean arterial pressure by norepinephrine infusion. So just for the respiratory strategy, I did not show you this slide this morning, just to alert you that the pressure support ventilation could be deleterious in this kind of patient. Look at here, you can see that this patient had spontaneous efforts, and so you cannot even you consider that you apply a low level of pressure. Actually, in this patient here, if the effort is low, you will have a low tidal volume, so a low transpulmonary pressure, or if the effort of the patient is high, you will have a high tidal volume and so a high transpulmonary pressure with some deleterious effect on the pulmonary circulation. And so you cannot monitor this kind of issue except if you just stay in front of the ventilator to see at each cycle which is the tidal volume, which is quite impossible. The second point is that in this situation, and I did not show you this slide this morning, if you apply a PEEP, especially when you have acute cor pulmonale, you may induce or worsen the pattern foramen ovale, and so the shunt between the right cavities and the left cavities. And look at this patient ventilated for RDS. You can see that we injected saline, agitated saline with air, and you can see here the right cavities, and you can see a large amount of bubbles passing from the right heart to the left heart, explaining, as Antonio explained us, a part of hypoxemia that you may observe. And it has nothing to do with the severity of lung injury. It's just the intracardiac shunt induced by PEEP, as shown in this study, because it's interesting. You can see here patient without the shunt, without the pattern foramen ovale. When you increase the PEEP, you increase the P/F ratio. But in patient with the pattern foramen ovale, when you increase the PEEP, you do not increase the P/F ratio, or more, you may decrease the P/F ratio. So just keep in mind that if there is something wrong regarding blood gas analysis, when you increase the PEEP in this kind of patient, probably you have to look for some shunt, intracardiac shunt. There are very famous names on this article. Some are in the room, so sorry for this for these guys who are in the room. That's obvious that I need to show you this recommendation from Berlin's roundtable, because it was in 2013. This is guidelines to treat RDS, and there is nothing regarding how to protect the right ventricle and to protect the the hemodynamics of your patients. Just look at the P/F ratio and adapt the treatment. In my feeling, Massimo and others, of course, it's absolutely not possible. We have now data to say that to protect the right ventricle and to protect hemodynamics may be a great help to save lives in this kind of patient. A few slides regarding fluid expansion. I said to you that you have to limit the fluid expansion, either because this is useless, and you know that the main objective of the right ventricle and the main reason why we have the right ventricle is to maintain as low as possible the CVP to promote the systemic venous return. In case of right ventricular failure, the CVP is increased, and so if you follow the Guyton curves, you understand that the systemic venous return decrease and fluid expansion is useless. And this was especially demonstrated in this study, and you can see that patients who were not responders to fluid actually had a dilated right ventricle compared to the patients who were responders to fluids. So when the right ventricle is failing or is dilated, fluids is useless. And this is, Jean-Louis, this slide is for you because you like very much this slide. You know very well this slide. This is the patient under mechanical ventilation for RDS. You can see the blood pressure variations. You can see that the delta PP was 27%. Look at after fluid expansion, no change in delta PP, no change in blood pressure, no improvement in hemodynamics. And look at how was the right ventricle. You can see a huge dilatation of the right ventricle and the right atrium. Look at how is bulging the right atrial septum toward the left atrium. And you can see a very severe constriction of the left ventricle. So do not give more fluids in this patient. First, is useless, and second, it could be deleterious by compressing more the left ventricle. A few words regarding the norepinephrine infusion. This is an experimental study by Guyton. Just to show you here, this is a model of obstruction at the pulmonary valve. And in this study, they progressively collapse the pulmonary annulus, so they progressively increase the right ventricular obstruction. And you can see just here the maximal pressure to which the right ventricle can compensate before to fail. And you can see that providing that you are able to maintain the blood pressure or the mean arterial pressure at the good level, the right ventricle is able to act against this obstruction because you maintain the coronary perfusion. But if you cannot maintain the blood pressure, you can see that the right ventricle is failing much earlier. So it's a key point to maintain the coronary perfusion, and the main drug to do that is to infuse norepinephrine to correct the mean arterial pressure. Look at here, a low systolic arterial pressure, 80. I don't remember the mean, but the mean was low. And you can see after norepinephrine infusion and restoration of the blood pressure, you can see a complete normalization of the right ventricular function. No paradoxical septal motion. And you have many data in animals, not so many in humans. Just look at this one. Maybe, yes, you see something. This is an experimental model of obstruction into the pulmonary circulation. This is a right ventricular and diastolic pressure at baseline. And after obstruction of the pulmonary circulation, you can see here that the right ventricular and diastolic pressure significantly increase. And look at after volume, it increased more, but it decreased after norepinephrine infusion. If you look at the cardiac output, normal cardiac output at baseline, look at after inducing the obstruction, a drop in the cardiac output, more decrease after volume. So it's really deleterious, first useless, but also deleterious. And you can see some restoration of cardiac output by norepinephrine infusion. And finally, if you look at the blood pressure, normal blood pressure at baseline, a drop in blood pressure during obstruction, a more decrease after fluid expansion, and a restoration of blood pressure by norepinephrine. So this is very logical that fluids is definitively useless in this kind of patients, and you have to promote norepinephrine infusion rather to give more fluids to the patient. Some rescue therapy. To conclude, I do not want to speak about prone position because now in my feeling prone position is not a rescue therapy. Prone position is really something that you have to apply in the most severe patient. But maybe for the future, rescue therapy could be the veno-arterial ECMO, and you have some cases in a massive pulmonary embolism, just to illustrate the fact, because it's interesting according to one of the previous presentations. You can see a young woman with acute cor pulmonale. Actually, it was acute and chronic. You can see the right ventricular dilatation. You can see the paradoxical septal motion. The hemodynamic situation was very severe, not under control. We decided to insert and to apply a veno-arterial ECMO. Look at here, the left ventricle was in a normal shape with a good contraction. And you can see after a VA ECMO, we were able to unload the right ventricle. Look at how now is not dilated the right ventricle. There is a decrease in the paradoxical septal motion, but you can see now, because probably of the effect of on the LV afterload, some decrease in LV contraction. So we did better on the right side, but we did worse on the left side. And another rescue therapy, I don't know if Daniel is in the room. Yes, he's there. Regarding nitric oxide, Daniel, because you asked me the question this morning. We do not have any data, just I can show you a case. This patient was under mechanical ventilation for RDS, very severe RDS. We adapt and we optimized in this patient the respiratory settings, and despite our usual approach, the hemodynamic status was really in a bad condition. Look at here, right ventricular dilatation, paradoxical septal motion, high dose of epinephrine, very low RV ejection flow. You can see in the pulmonary and shunt between the right atrium and the left atrium. So in this patient, we decided to give nitric oxide, and you can see a few hours later, the patient was less tachycardic. We decreased the epinephrine, and you can see a much better increase in RV ejection flow and a disappearance of the shunt between the right atrium and the left atrium. So we did better in terms of right ventricular function and right ventricular pressure. Thank you very much.